So the denture won't fit because of an undercut. The primary objective of soft tissue maxillary tuberosity reduction is to provide adequate intra-arch space for proper denture construction in the posterior area and a firm mucosal base of consistent thickness over the alveolar ridge denture bearing area. Maxillary tuberosity reduction may require the removal of soft tissue and bone to achieve the desired result. The amount of soft tissue available for reduction can often be determined by evaluating the presurgical panoramic radiograph. In a radiograph, if a radiograph is not of a quality necessary to determine soft tissue thickness, this depth can be measured with a sharp probe after local anesthesia is obtained at the time of surgery. Next question. LED curing versus regular curing. Why is LED curing better? Answer: the range. It lasts longer. LED range of 400 to 499 nanometers or 460 to 490 nanometers. It causes damage to retina of eye. The depth of 2 millimeters. Most recently developed are the LED curing units. These units have a number of advantages compared to other curing units, including a wavelength spectrum emission that is closely matched to camphorquinone. What is camphorquinone? Camphorquinone is a photoinitiator. Molecule. So the camphorquinone is a photoinitiator. So, most recently developed are the LED curing lights. These units have a number of advantages compared to other curing lights units, including a wavelength spectrum emission that is closely matched to camphorquinone, which is a photoinitiator. Okay. In addition, these units are more energy efficient, allowing them to be battery operated. The diodes have a lifespan that is approximately 1,000 times longer than the typical halogen bulb. While the earlier versions of LED curing units provided inadequate irradiance, the new generation has overcome this deficiency. About the only disadvantage to these units is the narrow wavelength spectrum, limiting their usefulness in curing any materials that do not use camphorquinone as a photoinitiator. Again, about the only disadvantage that these units have is the wave spectrum, limiting their usefulness to curing any materials that do not use camphorquinone as a photoinitiator. The practical consequence is that curing depth is limited to 2 to 3 millimeters unless excessively long exposure times are used, regardless of lamp intensity. Next question. So, test for boy or girl chi-square. The chi-square test measured the association between two categorable variables. The t-test is statistical difference between two median. Example, the difference between the control group and a group receiving the treatment. So, chi-square test. Chi-square test. The chi-square test, also written X2 test, is a statistical hypothesis is a statistical hypothesis test where the sampling distribution of the test statistic is a chi-square distribution when the null hypothesis is true without other qualification. Chi-test square often is used as short for Pearson's chi-square test. Okay. It is used to determine whether there is a significant difference between the expected frequencies and the observed frequencies in one or more categories. Next, how do you know if it's a non-odontogenic tumor? Pain doesn't subside. A non-odontogenic tumor toothache can often be differentiated from odontogenic toothache by local provocation. Pulpal and periodontal pains are increased by local provocation of the teeth, such as percussion, cold, or biting forces. Again, non-odontogenic tumor toothache can often be differentiated from odontogenic toothache by local provocation. Pulpal and periodontal pains are increased by local provocation of the teeth, such as percussion, hot, cold, or biting forces. When toothache pain is not increased by provocation, one should be suspicious of non-dental toothache. Local anesthetic can be very helpful in differentiating true dental pain from pain referred to the teeth. Local anesthetics applied to the region of a true dental toothache will reduce or eliminate the pain. Local anesthetics at the site of the non-odontogenic toothache often will not reduce the pain, since the site of pain is not the true source of pain. So a question that says odontogenic tumor relieved by aspirin, what is it? So odontogenic not relieved by aspirin is osteoma. Or osteoblastoma. Next question, the difference between a 245 burr and a 330 is that the 245 is longer. The 245 has an inverted cone and the 330 is pear-shaped. So the 245 is a longer burr. Next, what turns porcelain green? Copper or silver? Porcelain that is baked on a high fusing gold alloy. Porcelain that is baked onto a high fusing gold alloy may exhibit a green discoloration due most likely to contamination of the metal by copper traces. Examples of metallic oxides in their respective color contributions to porcelain include iron or nickel oxide, brown, copper oxide, Again, examples of metallic oxides and their respective color contributions to porcelain include iron or nickel oxide, brown, copper oxide, green, titanium oxide, yellowish brown, lavender, manganese oxide, lavender, and cobalt oxide, blue. Opacity may be achieved by an addition of cerium oxide, zirconium oxide, titanium oxide, or tin oxide. Referred pain. Pain experienced from a site other than the site of a stimulus or tissue damage. Afferent fibers from several sites, possibly some distance from each other, converge on second order neurons. The central cognitive processes mistake the true site. Okay, again, pain experienced from a site other than the site of stimulus or tissue damage. Afferent fibers from several sites, possibly some distance from each other, converge on second order neurons. Then central cognitive process mistake the true site. Next question. Warfarin, Coumadin, what test do you use? INR. INR needs to be within 24 hours pre-surgery. INR of 1 is normal. Warfarin can be monitored via PT, which is extrinsic pathway. Patients who take warfarin, Coumadin, or Coumadin, that's also the other name, for anticoagulation must have a current international normalized radio determined before any invasive procedure can be performed. Most dental procedures, including minor surgery, may be performed safely without discontinuation or alteration of the Coumadin dosage, as long as the INR is within the therapeutic range. Local hemostatic measures generally are adequate to control bleeding and include the use of hemostatic agents in the sockets, suturing, gauze pressure packs, and tranexamic acid or E-aminocaproic acid mouth rinses. E-aminocaproic acid mouth rinses, and tranexamic acid. More extensive surgical procedures associated with anticipated significant blood loss should be discussed with the patient's physician. Tranexamic acid is mentioned here as one of the hemostatic agents. Tranexamic acid is used to treat heavy bleeding during your menstrual period. Tranexamic acid works by slowing the breakdown of blood clots, which helps to prevent prolonged bleeding. Is a medication used to treat or prevent excessive blood loss from major trauma. Tranexamic acid. Postpartum bleeding, surgery, tooth removal, nosebleeds, and heavy menstruation. Also used for hereditary angioedema. It is taken either by mouth or injection into a vein. Okay, so tranexamic acid is another way to achieve hemostasis. And another one is the E-aminocaproic acid. Aminocaproic acid is a derivative of an analog of amino acid lysine, which makes it an effective inhibitor for enzymes that bind that particular residue. Such enzymes include proteolytic enzymes like plasmin, the enzyme responsible for fibrinolysis. For this reason, it's effective in the treatment of bleeding disorders. Aminocaproic acid, then in tranexamic acid. More extensive surgical procedures associated with anticipated significant blood loss should be discussed with the patient's physician. Next, how do you place implants from tooth? How far do you place implants from tooth? Here is an image. 1 millimeter from the tooth, 3 millimeters from implant to implant. Implants should be placed at least 3 millimeters apart from each other and 1 millimeter from adjacent teeth. The recommended minimum distances in millimeters between implants and between implants and natural teeth. Next question. Remove rampant caries from anterior curettage. What part of the blade do you use in perio? You use the lower third. A Gracie curette blade divided into 3 segments. A. The lower 1/3 of the blade, consisting of a terminal few millimeters adjacent to the toe. B. The middle 1/3, and C. The upper 1/3, which is adjacent to the shank. If only the middle third of the working end is adapted, again, if only the middle third of the working end is adapted on a convex surface so that the blade contacts the tooth at a tangent, the toe or sharp tip will just jut out into soft tissue, causing trauma or discomfort. Again, if only the middle third of the working end is adapted so that the blade contacts the tooth at a tangent, the toe or sharp tip will jut out into soft tissue, causing trauma or discomfort. If the instrument is adapted so that only the toe or tip is in contact, the soft tissue can be distended or compressed by the back of the working end, also causing trauma and discomfort. A curettage that is improperly adapted in this manner can be particularly damaging because the toe can gouge a groove the root surface. Only the lower third or half of the Gracie blade is in contact with the tooth during instrumentation. Concentrate on using the lower third of the cutting edge for calculus removal. So only the lower third. Next question. Pregnant lady. A pregnant lady, you have to lay the right side up. What is the artery that you're protecting? Answer. During late pregnancy, a phenomenon known as supine hypotensive syndrome may occur that manifests as an abrupt fall in blood pressure, bradycardia, sweating, nausea, weakness, and hunger when the patient is in supine position. Symptoms are caused by impaired venous return to the heart that results from compression of the inferior vena cava by the gravid uterus. This leads to decreased blood pressure, reduced cardiac output, and impairment of loss of consciousness. The remedy for the problem is to roll the patient over onto her left side with the right hip up. which lifts the uterus off the vena cava. Blood pressure should rapidly return to normal. Next question. If a patient is laying backwards and going into syncope, what is being smushed? The abdominal aorta is the answer. We're going to do a quick search on that. Abdominal aorta being smushed, squashed. Anyway, let's go back to the questions. A mandibular incisor coming in crowded. How do you make space? Inter-arch distance from the primitive space is the answer. Again, mandibular incisor. Mandibular incisor coming in crowded. How do you make space? Inter-arch distance from primitive space. Next, periapical abscess versus periapical radiolucency. Which do you see first? Endo, then perio. The question we had seen before, mandibular incisor coming in crowded. How do you make space? Inter-arch distance from primitive space. Distal to the canine for mandibular arch and mesial to canine for maxillary arch. Distal to canine for mandibular arch, mesial to canine for maxillary arch. So again, mandibular incisor coming in crowded. How do you make space? The inter-arch distance from primitive space. If it's distal to canine, it is a mandibular arch. And if it's mesial to canine, for maxillary arch. Question. There are three types of injuries to nerves: neuropraxia, axonotmesis, and neurotmesis. Neuropraxia is the least severe form of peripheral injury. It's a contusion of a nerve in which continuity of an epineurial sheath in the axons is maintained. Blunt trauma or traction, i.e., stretching of a nerve, inflammation around the nerve, or local ischemia of a nerve can produce neuropraxia. Because there has been no loss of axonal continuity, spontaneous full recovery of the nerve functioning usually occurs in a few days or weeks. This is blunt trauma or traction of a nerve, inflammation around the nerve, or local ischemia of a nerve. Neuropraxia. Again, because there has been no loss of axonal continuity, spontaneous full recovery of a nerve function usually occurs in a few days or weeks. Three types of peripheral nerve injury: neuropraxia, injury to nerve causes no loss of continuity over the axon or epithelium. Examples shown in is implant placed in inferior alveolar canal, compressing the nerve. And here you see it. It's just a compression. The next one is axonotmesis. Is an injury to nerve that causes the loss of axonal continuity but preserves endoneurium. The example shown here is aggressive retraction of the mental nerve. So first neuropraxia, then axonotmesis, then neurotmesis. Neurotmesis is injury to nerve. Injury to nerve causes loss of axonal and endoneurium continuity. The example is the cutting of the inferior alveolar nerve during removal or deeply impacted third molar. Now, axonotmesis, which is the just for injury that is caused by a loss of axonal continuity but preserves the endoneurium, like a retraction of the mental nerve, for example. Axonotmesis has occurred when the continuity of the axons but not the epineurium sheath is disrupted. That is axonotmesis. Think about the axons, they're still there. Severe trauma, nerve crushing, or extreme traction of a nerve can produce this type of injury. Because the epineurial sheath is still intact, axonal regeneration can, but does not always occur, with a resolution of nerve dysfunction in about 2 to 6 months. Neurotmesis is the most severe type of injury. It involves complete loss of nerve continuity. This form of damage can be produced by badly displaced fractures, severance by bullets or knives during an assault, or by iatrogenic transection. Prognosis for spontaneous recovery of nerves that have undergone neurotmesis is poor, except if the end of the affected nerve has somehow been left in an approximation and properly oriented. Next question. A key to root canal therapy is cleaning and shaping. Why did it fail, the root canal therapy? Answer. Most non-healing or failures of root canal treatments is directly or indirectly caused by bacteria somewhere in the root canal system. In general, the most common causes of failure are: number 1, errors in diagnosis and treatment planning; 2, coronal leakage; 3, lack of knowledge of pulp anatomy; and 4, inadequate debridement and or disinfection of the root canal system; 5, inadequate restorative protection; 6, operative errors; 7, obturation deficiencies or errors; and 8, vertical root fracture. Inadequate debridement is very important, or disinfection of the root canal system. Next question. Manic depressive not taking their medicine, what will happen? Mood swings. Drug therapy is essential in bipolar disorder for achieving 2 goals: rapid control of symptoms in acute episodes of mania and depression, and prevention of future episodes or reduction of their severity and frequency. Again, drug therapy is essential in bipolar disorder for achieving 2 goals: the first goal is a rapid control of symptoms in acute episodes of mania and depression, and the prevention of future episodes or reduction of their sensitivity and frequency. Mood disorders have a tendency to occur. Affective episodes may occur spontaneously or may be triggered by adverse effects. Individuals with mood disorders and their families must become aware of the early signs and symptoms of affective episodes so that treatment can be initiated. These individuals also must be made aware of the need for medication compliance and the medication's adverse effects and possible complications. Next question, Banding loop for first primary molar. A banding loop space maintainer. The placement of a space maintainer must not compromise a permanent tooth. Bands should be cemented with a luting glass ionomer as a protection against caries and the appliance reviewed regularly. As the premolar erupts, the appliance is removed when there is interference with normal emergence. The distal shoe is the appliance of choice when a primary second molar is lost before eruption of the permanent first molar. Next question. A 5-year-old child having pain, what do you give them? Acetaminophen, aspirin, ibuprofen, or codeine. You give them Tylenol, acetaminophen. Aspirin compounds are non-steroidal anti-inflammatory agents, but they are contraindicated because about 4% of the patients experience wheezing after taking these drugs. Acetaminophen is the recommended medicine. Next question. Peripheral cemento-osseous dysplasia. Peripheral cemento-osseous dysplasia is a reactive process of a known cause that requires no treatment. Its clinical features are they're commonly seen at the apices of one or more mandibular anterior teeth. There is no symptoms. The teeth are vital. Most frequently seen in middle-aged women. Starts as circumscribed lucency which gradually becomes opaque. An exuberant form that may involve the entire jaw is known as florid osseous dysplasia. And here we have an X-ray of periapical cemento-osseous dysplasia. You can see all of this. Periapical cemento-osseous dysplasia. Next question. Which least likely to have hepatitis B? A diabetic. Hepatitis B virus. Its etiology. The disease is produced by a highly infective virus known as the Dane particle. This intact virus consists of an inner core antigen, HBcAg, and an outer coat surface antigen, HBsAg. Risk of transmission, 30% after percutaneous injury from an infected patient, as little as 1 times 10 minus 8 milliliters of blood can transmit the disease. Hepatitis B virus is diagnosed based on a physical examination, medical history, and blood tests. Hepatitis B virus blood tests include hepatitis B antigens and antibodies, and hepatitis B viral DNA, which detects genetic material from the hepatitis B virus. As a prevention, A vaccine to immunize recipients against hepatitis B virus is available. 3 doses are given to confirm immunity. An initial dose, followed by a second dose at 1 month, and then a third dose at 6 months after the first one. Since hepatitis B virus is highly infectious, all dental personnel should be vaccinated against hepatitis B virus. Next question. Freeze-dried bone is an allograft. Several clinical studies report that bone fill exceeding 50 to 67% of the defects grafted with freeze-dried bone allograft, and a 78% of the defects grafted with freeze-dried bone allograft plus autogenous bone, however, is considered an osteoconductive material, whereas decalcified freeze-dried bone allograft is considered an osteoinductive. So, the difference between osteoconductive and osteoinductive. The laboratory studies have found that decalcified freeze-dried bone allograft has a higher osteogenic potential than only FDBA or just freeze-dried. So the decalcified one has a higher osteogenic potential because in periodontal defects it results in significant probing depth reduction, attached level gain, and osseous regeneration. The combination of these decalcified, freezed, dried bone allograft and GTR, which GTR is the has also proven to be very successful. However, limitations of the use of decalcified freezed dried bone allograft include the possible, although remote, potential disease transfers from the cadaver. So, osteoconductive is just freeze-dried. Osteoinductive is decalcified, freeze-dried. So, the conductive has a potential to serve as a scaffold that favors outside cells to penetrate the graft and form new bone, whereas the decalcified freeze-dried bone allograft is osteoinductive, which has the ability of the graft to contain molecules that convert neighboring cells into osteoblasts, thus increasing the ability of the graft to induct formation or genesis of bone. Next, OKCs. Odontogenic keratocysts is an important entity to differentiate from other odontogenic cysts because often appears very aggressive. OKCs can be seen at any age but are most often diagnosed in patients between 10 and 40. They occur mostly in males within the posterior mandible. Radiographically, OKCs present as well-defined unilocular or multilocular radiolucencies. Histologically, the cyst lining consists of a thin layer of parakeratinized or orthokeratinized stratified squamous epithelium with a prominent basal cell layer and a corrugated appearance of the epithelial surface. The treatment requires aggressive and complete removal of the lesion, as recurrence rates for inadequately removed lesions can reach 60%. Multiple OKCs may occur. These patients should be evaluated for nevoid basal cell carcinoma syndrome or Gorlin syndrome. Now, nevoid basal cell carcinoma syndrome is an autosomal dominant inherited condition that exhibits high percentage of variable expressibility. The syndrome is caused by mutations of patched a tumor suppressor gene. A patch is a gene suppressor, a tumor suppressor gene that has been mapped, and the chief components are multiple basal cell layer, basal cell carcinoma of the skin, odontogenic keratocysts in the posterior mandibule, intracranial calcification, falx cerebri and frontal bossing, and rib and vertebral anomalies. Many other anomalies have been reported in these patients and probably also represent manifestations of the syndrome. The prevalence of Gorlin syndrome is estimated to be about 1 in 60,000. Next question. We have a number 8 with a reduce a gingival need. Reduce on the gingival margin and needs crown lengthening. Okay. So, surgical crown lengthening procedures are performed to provide retention form to allow a proper tooth preparation and impression procedures and placement of restorative materials, and to adjust gingival levels for aesthetics. It is important that the crown lengthening surgery is done in such a manner that the biologic width is preserved. The biologic width, junctional epithelium, and connective tissue attachment. This is the biological width. The biological width is defined as the physiologic dimension of the junctional epithelium and the connective tissue attachment. This measurement has been found to be relatively constant at approximately 2 millimeters. The healthy gingival sulcus has shown an average depth of 0.69 millimeters. Again, the healthy gingival sulcus has shown an average depth of 0.69 millimeters. Okay, gingival sulcus. The healthy gingival sulcus has shown an average of depth of 0.69 millimeters. It has been theorized that infringement of the biologic width of the placement of a restoration within its zone may result in gingival inflammation. It has been theorized that infringement of the biological width by a placement of a restoration within its zone may result in gingival inflammation. The biologic width has been estimated to be about 2 millimeters. Again, biologic width has been estimated to be about 2 millimeters. Here you see 0.97 and here you see 1.07. The healthy gingival sulcus has shown an average depth of 0.69 millimeters. Again, it has been theorized that infringement of the biological width by the placement of restoration within its zone may result in gingival inflammation. The biologic width has been estimated to be about 2 millimeters. Efforts should be made to preserve its integrity. Remember that biologic width is the junctional epithelium plus the connective tissue attachment. Junctional epithelium and connective tissue attachment. Pocket formation and alveolar bone loss. Consequently, it is recommended that there be at least 3 millimeters between the gingival margin and the bone crest. Here you see the gingival margin and the bone crest, about 3 millimeters. This allows for adequate biologic width when the restoration is placed 0.5 millimeters within the gingival sulcus. 0.5 millimeters within the gingival sulcus, so about here. If the average of the gingival sulcus is 0.69. Within the gingival sulcus, surgical crown lengthening may include the removal of soft tissue or both soft tissue and alveolar bone. Reduction of soft tissue alone is indicated if there is adequate attached gingiva and more than 3 millimeters of tissue coronal to the bone crest. This may be accomplished by either gingivectomy or flapped technique. Inadequate attached gingiva and less than 3 millimeters of soft tissue require a flap procedure and bone recontouring. Again, inadequately attached gingiva and less than 3 millimeters of soft tissue require a flap procedure and bone recontouring. In the case of caries or root fracture, to ensure margin placement, again, in the case of caries or tooth fracture, to ensure margin placement on sound tooth structure in a retention form, the surgery should provide at least 4 millimeters from the apical extent of the caries or fracture to the bone crest. So if the caries is here, you should make sure that this lower part gives you at least 4 millimeters to this. So you can lower this bone so you have your 4 millimeters if your caries is here. So from here to here, you gotta give it 4 millimeters so you can make that bone go more apical. Again, in the case of caries or fractures, to ensure margin placement on sound tooth structure and retention form, the surgery should provide at least 4 millimeters from the apical extent of the caries or fracture to the bone crest. Next question. H2 histamine gastric reflux. H2 histamine reflux receptor blockers inhibit the action of histamine on the parietal cell of the stomach. H2 can treat Zollinger-Ellison syndrome, GERD, acid reflux. Examples are cimetidine, ranitidine, famotidine, nizatidine, omeprazole, and lansoprazole. Next question. Which is in the hundreds? Hue, value, or chroma? Answer, hue. Next, papilloma. The squamous papilloma is a soft, painless, usually pedunculated exophytic nodule with numerous finger-like surface projections that impart a cauliflower or wart-like appearance. Next, apexification. When do you use non-vital? Want to close apex. Apexification is when do you use non-vital? Okay, apexification, when do you use it? When you have a non-vital teeth and need to close the apex. Apexification is a method of treatment for immature permanent teeth in which root growth and development caused due to pulp necrosis. Its purpose is to allow the formation of an apical barrier. Apexification is most often performed in an incisor that lost vitality after a traumatic injury. It may also be indicated in non-vital immature teeth after caries exposures and in certain anatomic variations, such as dens invaginatus. When a diagnosis of irreversible pulpitis, pulp necrosis, or acute or chronic apical periodontitis has been established, treatment should be planned. Again, when a diagnosis of irreversible pulpitis, pulp necrosis, or acute or chronic apical periodontitis has been established, treatment should be planned. The most important consideration is whether the tooth can be restored to function and aesthetics. The apexification procedure can be done in a young patient with short roots. However, because of the long duration of the treatment, patients' and parents' compliance is required. Apexification is a predictable procedure, and an apical barrier will be formed in 74% to 100% of the cases. The most common complication is cervical crown or root fracture, because the cervical portion of the root is very thin and may fracture easily. Apexification is traditionally performed using calcium hydroxide dressing that disinfects the root canal and induces apical closure. The high pH and low solubility of calcium hydroxide keeps its antimicrobial effect for a long period. Sequeira and Lopez discussed the mechanism of its antimicrobial activity in detail. Calcium hydroxide assists in the debridement of the canal, as it increases the dissolution of necrotic tissue when used alone or in combination with sodium hypochlorite. Apexification requires multiple visits and could take a year or more. To achieve a complete apical barrier that would allow root canal filling using gutta perca and sealer. The time needed for apexification depends on the stage of a root development and the status of the periapical tissue. So now on the other side, apicoectomy or apicectomy. Um, what are the indications for an apicectomy? When there is a persisting or enlarging periradicular pathosis following non-surgical endodontic treatment. What are the indications? Again, persistent or enlarging periradicular pathosis following non-surgical endodontic treatment. And non-surgical endodontics is unfeasible when a marked overextension of obturating materials is interfering with healing. Biopsy is necessary. Access for root end preparation and root end filling is necessary. When the apical portion of the root canal system with periradicular pathosis cannot be cleaned, shaped, or obturated. And apicectomy again, indications are a persistent or enlarging periradicular pathosis following non-surgical endodontic treatment, and non-surgical endodontics is unfeasible when a marked overextension of obturating materials is interfering with healing. Biopsy is needed. Access to root end preparation or root end filling is necessary, and when the apical portion of the root canal system with periradicular pathosis cannot be cleaned, shaped, or obturated. Next question. Calcified canal. What do? You refer. Next. When is it okay to do a temporal fixing on patient on an emergency? What is the incidence? Incidence indicates the number of new cases that will occur within a population over a period of time. The incidence of people dying of oral cancer is 10% per year in men aged 55 to 59 in our community, and incidence is measured of 100 over 1,000. So the incidence equals number of cases in the incidence over the total number of people at risk. So if you have 100 cases of a certain pathosis over 1,000 people, which are the total number of people at risk. Next question. Principle of tell, show, do. The great majority of children require minimal management efforts other than providing information on what is going to happen. Tell, show, and do. An important thing is that every child responds to his or her environment with an individualized style. Next question. How do you get a child acting out to act favorably? Let them watch another child behaving. Many practitioners have long used modeling strategies by letting the young children watch big sister through the appointment if they perceive a positive relationship between a confident sibling and the fearful child. A simple variation of this strategy involves scheduling an unrelated fearful child to watch another child patient during his appointment. Next question, fibroma. This is what fibroma looks like. Fibroma. Next question, cancer translocation, P53 gene. P53 gene is a gene related with cancer translocation. Okay, so P53 gene cancer translocation P53 gene. We're gonna check online about P53 gene. Quick search. P53 is a tumor protein. P is for protein, okay? And it's a gene that codes for a protein that regulates cell cycle and hence functions as tumor suppression. It is the most frequently mutated gene in human cancer, indicating that P53 gene plays a crucial role in preventing cancer formation. So P53 gene, cancer translocation. Next question. Greatest degree of linear coefficient of expansion? Resin. Composite resin is 2.5 times greater than tooth structure when subject to extreme changes in temperature than other materials. Direct gold is similar to tooth but higher, and amalgam is 2 times more than the tooth. So gold is the closest one in expansion to tooth. Resin is the one that expands 2.5 times more, and amalgam is 2 times more than teeth. So resin is still a bit more than amalgam. Next question, 53. Calcification sequence. This is a very important point, and it will be pretty long too. From 7 months to 3 years, the primary sorry, you'll have to check all these calcification sequence, 7 months to 3 years. The primary at 14 weeks, central incisor. 15 weeks, first molar. 16 weeks, lower incisor, I guess. 17 weeks, C. 18 weeks, second molar. All these weeks are in utero. And the sequence is A, B, D, C, E. A, B, D, C, E. Now in permanent, at birth, the first molar, 6 months, anterior teeth except maxillary L, I. Well, just you're gonna have to read this in a book with images because it's hard to memorize like this. Class 3, cleft palate and cleft lip. In class 3 refers to let me see, in what is class 3 in maxillary malocclusions, I guess, or orthodontic treatment. I don't know exactly what is the question, but it says class 3, cleft palate and cleft lip. We're gonna pause here so we can continue on the next video.